System Group, Health System Global, members of that global association. I'm sure that they're also here with us. And then members of Association of Public Health Physicians of Nigeria, especially the Health System Caucus of that association. I'm sure that they're here. So you're all welcome to this day. And of course, students of lecturers, students, supervisors of the School of Public Health. I'm sure that we are all here. Yesterday, attendance was more than, we recorded more than 300 on the Zoom call, and then even more, much more, and they much more watched the streaming live on YouTube. So I'm sure that today is probably may even break that record. So you are welcome. So let me start with my welcome address. I'm presenting. My name is Professor Best Odinoha, the Director of the School of Public Health. So this is my welcome address on this day, day 5 of the first scientific conference of the School of Public Health, holding virtually on Friday, 19th September 2025. Protocol, I think I have to go straight since the Vice Chancellor and the others are not here. I want to go straight to those that are present. Those that are not present, we have fully recognized them. So, so on this, on the protocol list, let me start with the chairperson of the day, Professor Seyefa Brisibe, Professor of Family Medicine and Health Systems, and the Honorable Commissioner for Health, Bayelsa State, a 1995 graduate of the University of Medical School and a fellow of the National Postgraduate Medical College in Family Medicine. Then we have the keynote speaker, Dr. Obinna Oleribe, is currently the assistant as a professor of Healthcare Management, School of Public Health and Health Sciences, California State University. So the deans and the directors, in fact, I'm sure that Professor Gaji is here, the director of the African Center of Excellence for Public Health and Osteological Research, is here in his dual capacity of both the center leader and the coordinator of the health system program of the School of Public Health. Of course, the panelists of the day, the panel discussants on the theme of the day, which is on equity in healthcare delivery in a changing disease landscape. And they include Dr. Claribel Abam, former Executive Secretary, Rivers State Rivers State Primary Health Care Management Board, Dr. Uveti Agala, Executive Secretary, Rivers State Contributory Health Scheme, Professor Ijoman Doka, Chief Medical Director of the Abia State University Teaching Hospital. Distinguished guests, professors, lecturers, and supervisors of the University of Port Harcourt School of Public Health. I want to especially recognize Professor Tobin West, my deputy and former CMD of our teaching hospital, University of Port Harcourt Teaching Hospital. I want to also recognize the presence of Professor PSC Uzoshuku and other distinguished members of the Health System Global, a global membership-based society founded in 2012 and dedicated to advancing the field of health policy and system research. I want past and present lecturers of the Department of Preventive and Social Medicine, Professor Dr. PNC Apowa, Dr. Messi Okoye, Dr. Professor Douglas, Dr. Jule, Dr. Alabere, Dr. Moore, Dr. Kano, Professor Madoka, Dr. Offrom, and others. Management and staff of the University of Port Harcourt School of Public Health, especially, particularly the admin secretary, colleagues and students of the School of Public Health, ladies and gentlemen, it is with great honor that I welcome you all to day 5 of the first annual scientific conference of the University of Port Harcourt School of Public Health, the day dedicated to health system management. The University of Port Harcourt was established, the University of Port Harcourt School of Public Health was established in January 2019 by the Senate of the University of Port Harcourt as a semi-autonomous academic center to provide postgraduate education in health, in public health, and the allied health sciences. The semi-autonomy of the University of Port Harcourt School of Public Health gives it the power to set and collect fees and then use the collected fees to run the academic programs of the school, but subject to the rules and regulations of the university. This gives the school the wherewithal to recruit and pay ad hoc lecturers from all over the world, all over the country, from within and outside the university. So the school is thus able to recruit the rich talents in NGOs, private and public organizations in Nigeria, ensuring that it has world-class faculty with diverse background, experience, and training. The University of Port Harcourt School of Public Health has been so successful in recruiting the best talents that it is increasingly finding it difficult to find external examiners who have not had any formal contact with his students. Anyway, it's a good problem to have. Okay, so the school started with 4 academic programs, but currently has 3 PhD programs, 10 master's program, a doctor or public health program, which is a professional PhD, a professional doctorate, and PhD programs in all the subspecialties of public health and the health sciences. Academic programs in the School of Public Health are deliberately designed to be both academic and professional, to sharpen the research skills of students and prepare them for a career in the academics, while emphasizing the practical skills that are needed for professional work. The result of these have been very remarkable, as the graduates of our various programs often secure employment few months after graduation and are known to perform much better than others. So whereas the problem of graduate unemployment exists in Nigeria, I don't think it is not a very big problem in the School of Public Health, because more than 30% of our graduates will probably get jobs within 6 months of graduation, and I'm sure that this even will increase, or the proportion will increase after 1 year, and definitely within 2 years. So it's a good achievement. The success of our graduates, even in the labor market, and their achievements in their jobs, can be attributed to our competency-based curriculum, expertly delivered by our lecturers who are drawn from the academia, the industry, and government, what is called the triple helix model. We not only teach the principles, we not only teach the principles, we not only teach the principles, um, we not only teach the principles as is standard in most public health academic programs in Nigeria, but also lay emphasis on the practice to ensure that the graduates of our academic programs are industry ready. Practice is embedded in every lecture given and reinforced with case studies. Perhaps we are the only school of public health that routinely use case studies in our everyday lecture. Our students also have access to short courses that teach specific competencies that are relevant to their program of study that are certificated separately. At present, most of the short courses offered to our students are developed from within the school, but we are also looking at the option of enrolling our students in other short courses, particularly those hosted by professional association. So let me use this opportunity to call on to appeal to the health system caucus of the Association of Public Health Physicians and this new organization. Anyway, suggested to me by the distinguished professor BSc Uzochukwu. So we can collaborate to run competency-based short courses, because at the end of their program, our students do not just go with one certificate, but several proficiency certificates of those short courses. Equity in healthcare delivery in a changing disease landscape is the theme of day 5 of this scientific conference. It gives us the opportunity to take another look, to explore other ways of making changes to our health system to deal with the changing diseases or changing disease pattern. We need to change from the acute care model to the chronic care model of healthcare to properly deal with the rising prevalence of non-communicable diseases. This will require new treatment modalities, new health workers, and the retooling of existing health workers. So, which means I'm charging our resource persons to look into this. The use of drugs in the treatment of diseases, they need to be complemented with diet and physical activities. And experts in health system management like you, especially our invited panelists and keynote speakers, they need to find innovative ways to mainstream these treatment modalities. So it is not, so right now, the health system shouldn't just depend on drugs for the treatment of diseases, but should also explore other treatment modalities, especially diet and physical activity. We need to look at new health workers. New health workers need to be recruited, especially patients. In fact, patients should be recognized as health workers because they, in some non-communicable diseases like diabetes, they can provide up to 95% of the treatment that they receive. Therefore, we must find innovative ways to teach them what to do, how to do them, and how and when to do them. Indeed, patient education programs are already the cornerstone of the management of chronic diseases like diabetes in developed countries. Again, also, faith healers and traditional medicine practitioners need healthcare. Provide healthcare to several Nigerians, especially social and mental health care. They also need to be fully brought into the health system to work more closely with community health workers in the provision of culturally acceptable but scientifically sound healthcare to Nigerians. Even the existing health workers, we need to look at them, look at their job descriptions, because with the new diseases we are dealing with, they probably will need to be retooled. But the one that is almost like an emergency, the one that the health workers that are almost becoming an emergency situation that we'll need to deal with uh, are the community health practitioners. They were recruited and trained to meet the need of providing healthcare to as close as possible to where people live and work. They were recruited. When they were first recruited, it was almost like it was an in-service, and they were recommended by members of their communities, and it was actually based on need. It was based on need, and they were trained in schools of health technology. Now, these schools have liberalized the admission criteria, in which any person that wants to get trained will apply, and they will admit and train them. So, but unfortunately, this has resulted in the graduation of thousands of community health practitioners. And meanwhile, they were originally trained to work within the government setup. So right now, how do you deal with them? What do you do with them? That is what we need to work on. That is what we need to work on. Also, we have to also consider healthcare financing, and I'm happy that Dr. Betty Agala is here, because with the rising prevalence of non-communicable diseases, there is a very big need for us to look at healthcare financing, especially healthcare financing. Health insurance, especially social health insurance, is a well-recognized way of preventing catastrophic health spending. But the operation of social health insurance in Nigeria, I must say, has not met the desired objectives, perhaps because it lacks social solidarity, and there is a different scheme for the poor and another one for the rich, thus ensuring or making it impossible for the premium paid by the rich to be used to subsidize the healthcare of the poor. So specialists in healthcare financing, they must look into the problem and find urgent solution. If not for anything, but to belie the statement that is commonly said, that all things good and beautiful, Nigerians destroy them all. We must work to disprove this statement. The chairman of the day, the guest keynote speaker, and panel discussants on the theme of the day were chosen because of their unique qualifications and experience. The chairman of the day, for example, Professor Seifa Bisbe, is a professor of family medicine and health system, and currently the current Honorable Commissioner for Health of Bayelsa State. Is a 1995 graduate of the University of Port Harcourt Medical School, and holder of the fellowship of the National Postgraduate Medical College of Nigeria in from the University of Birmingham, an MBA from an ABA from London Metropolitan University, and a diploma in development management from Coventry University. Very highly qualified with rich experience. And the keynote speaker, Dr. Oleribe, has a rich experience in Nigeria and even in 3 continents, in Africa, in Europe, and in the US. He is a 1995 graduate of University of Port Harcourt, where he graduated as the best graduating student. He holds an MPH from the University of Benin, a Doctor of Public Health from Warden University, USA, and the fellowship of both the Royal College of Physicians, London, and the West African College of Physicians. Highly experienced, highly trained. The panel discussants are also very experienced. Dr. Claribel Abam is the pioneer executive secretary of the Rivers State Primary Healthcare Board. Very experienced public health practitioner, and he has experience in other areas of public health. Dr. Veti Agala, currently the executive secretary of the Rivers State Contributory Healthcare Scheme. Another very experienced person, Professor Ijoma Ndoka, CMD of the Abia State University Teaching Hospital, but also a medical doctor and fellow of the National Postgraduate Medical College in Public Health. So I have no doubt that they would do justice to the choosing team of the 5 of our conference. So let's sit back and listen to these experts. Welcome all. Thank you very much. Thank you for listening. So we will move on to the next item, and that is the chairman's speech. Chairman, Professor Brisbane, sir. Honorable Commissioner.
Yes. Good morning.
Good morning, sir. Go ahead with your opening remark.
All right. First of all, let me appreciate and recognize all the participants, the keynote speaker, the leadership of the School of Public Health, the panelists, and distinguished colleagues, esteemed guests, respected students and friends of UNIPORT. It is with profound humility and a deep sense of purpose that I speak before you today as chairman of this historic occasion, the first scientific conference of the University of Port Harcourt School of Public Health. Today, for me, is not merely an academic gathering. It is a defining moment in our shared pursuit of justice in healthcare, that health inequities are neither natural or acceptable, and that we as scholars, policymakers, practitioners, government, public servants have both the capacity and moral duty to change this reality. Allow me at this juncture to salute the visionary leadership that has made this day possible. The chief host, Professor Onaro Abraham Goodwill, the Vice Chancellor, the Director of the School of Public Health, Professor Best Odnar, the Coordinator, Professor Dapri Mogaji, and for your leadership and commitment. Reminds me that progress is not born out of chance, but out of courage and conviction, and in fact, commitment and dedication. To the organizing committee and the school, I extend my deepest appreciation for your tireless work in convening this landmark event. I know I was part of the beginning process, and today, as I listen to the leadership of this school expanding, giving reports of progress in terms of where we are now, from humble beginning of just 3 courses to this level where we have PhD in all subsectors and masters in over 10 courses. For me, that is tremendous, and I really want to appreciate you. I want to appreciate the school, and of course, being UNIPORT being my alma mater, and the College of Health Science is something that I want to appreciate, and I believe that all of us appreciate that, and just know that you have our support, even as we represent you in the public sector for what we are doing, and we respect and appreciate it deeply. The theme, equity in healthcare delivery in a changing disease landscape, could not be more timely or urgent. Across Nigeria and indeed across the world, the contours of disease are shifting. New pathogens emerge, non-communicable diseases surge, and climate changes threaten to redefine patterns of illness. Yet, amid all these challenges, one constant remains: inequity. The stark divide between those who can access and those who cannot, between the privileged who live longer, healthier lives, and the marginalized who bear the heaviest burden of disease, is real. As a physician who spent a lot of time in the front line, most especially in accident and emergency, and also in family medicine, I have seen the tragedy unfolding, not being medicine, not that because medicine does not have any answer, but because our systems deny patients or some access to some of these desired access. Our systems, our health systems, our environment, our health ecosystem is skewed in a way that there are those that are left out. There are those that cannot access a physician at the point of primary care. There are those that access others before a physician. And I believe that this inequity is important, and we need to have that discussion. And I'm happy that today, with the names that are on the giving the keynotes and also the panelists, I'm very, very sure that this topic will be completely and holistically x-rayed for the benefit of humanity. And of course, most recently, being a commissioner in Bayelsa State had made me to witness how geographical location, poverty, and structural neglect combine to rob our people of their right to health. These inequities are not by fate. They are choices sustained by systems and policies that we collectively must transform and change. And even as the co-chair of the National Emergency Medical Treatment Committee at the Federal Ministry of Health. It also brings to bear, and in real terms, the issues of inequity in access to healthcare, inequity in access to quality and quantity, as at the time people need health. You see cases of disproportionate disadvantage to some because they don't have vehicular means to be transported when they have emergencies. You see cases of some that have emergencies, and because they need to spend out of pocket, they cannot have the quantity and quality of care they need at that point in time. Let us be clear. Equity is not sameness. Equity is justice, fairness. It is ensuring that every person, irrespective of where they are born, where they live, what they earn, has a fair chance to reach their fullness health potentials, to assess quality, equitable, and fair healthcare. The World Health Organization reminds us that health inequities are man-made, shaped by power, policies, and resource distribution. That reality should disturb us, but it should also empower us, because what is man-made can be unmade, and what has been built unjustly can be rebuilt on the foundations of fairness. The evidence is sobering. In our nation, the gap in life expectancy between the most advantaged and the less advantaged, or the most privileged and the least privileged, is sometimes measured not just in years, but in decades. That gap is not just a number. It is a silent epidemic of lives cut short, dreams deferred, and communities held back from progress. In Bayelsa, our context is unique, but instructive. Our beautiful but challenging riverine terrain complicate access to care. Too many of our primary healthcare centers struggle without basic infrastructure, electricity, water, reliable cold chain for vaccines. Of course, these are issues that cut across the breadth and length of this country. Workforce shortages persist, and as many of our bright professionals are lured away for better opportunities, and diseases, both old and new, malaria, hypertension, diabetes, more continue to weigh heavily on our most vulnerable citizens. And of course, most recently, statistics show clearly that the non-communicable diseases are beginning to be of more burden than even the infectious diseases. So there is need for us to engage, interrogate the theme of this conference. Yet amid these challenges, there is also hope. With strategic partners, for us, we are beginning to strengthen healthcare systems, expand screening initiatives, where we recently launched Project 10 Million. And the whole purpose of this was to see that we are able to screen for non-communicable diseases, most especially hypertension and diabetes, to ensure that the management is early, and also advocacy is done so that the people can take charge of their health. At the national level, the Basic Healthcare Provision Fund is helping to bring essential services to the undeserved. The recent introduction of MENS 5CV and R21 vaccines is reshaping our approach to preventable diseases. And new investments in oncology and nuclear medicine infrastructure signal a readiness to reimagine imagine Nigeria's health landscape. But progress alone is not enough. We must press harder, move faster, dream bolder. For if health inequities remains, our gains, our outcomes will always fall short. That is why this conference is very, very vital. They remind us that equity is not an abstract policy area. It is the heartbeat of every successful health system. It demands transformation at every level. Allow me to highlight 5 imperatives for this journey: governance and leadership, community-centered approach, governance and leadership. We should be able to define who benefits, who is excluded, so that we can approach healthcare holistically. A community-centered approach, of course, getting communities to be involved, women leaders, religious leaders to be involved will bridge some of these gaps that we notice. Innovative healthcare delivery, of course, is important because when you have innovative healthcare delivery, where you deploy telehealth, where you deploy solar panel, alternative energy sources in our primary healthcare, and probably most recently, just like we're doing in Bayelsa State, deploy aerial logistic management technology. You see that medicines and vaccines can be taken to very, very remote areas where geography becomes a big problem, contributing to inequities in access to healthcare. Data-driven decision-making and workforce development. And I want to appreciate the school for looking at the area of human capacity development, and also appreciate you because I've had opportunity of engaging 1 or 2 of your products, and I must confess that you're doing a great job. And none of these that I've engaged have performed below average. So kudos to the school, Professor Best, for what you're doing for humanity and for the academic and the professional development. You cannot imagine it, because I must tell you that what you do, especially in the public health realm, have ripple positive effect, because you are not just a fisher of men, but you are also contributing immensely to changing our health outcomes around the world to the better end. To the students and young scholars here today, the future of health equity rests on your shoulders. Your research, your practice, your advocacy. These will shape the health systems of tomorrow. Be bold. Ask the uncomfortable questions. Let your career be driven not only by science, but by justice and compassion. To our keynote speaker, Dr. Oloribe, my friend, brother, and classmate, and our distinguished panelists, most especially to my boss and my mentor, Dr. Claribel Habam, your scholarship and service illuminates the path we must take. Thank you for leading with both intellect and integrity. Your footprints, even now and in the past, clearly shows that. I gotta thank you for your dedication to what you're doing in the healthcare finance space in Rivers State and to the country as a whole. As I conclude this session or this my address, I urge us all to remember equity is not a destination. It is a journey. And it's a journey we must walk with courage, persistence, and refusal to accept anything less than justice, fairness, equity for every citizen. Let this conference be more than an exchange of ideas. Let it be the spark of a movement. Let it echo from Port Harcourt to Bayelsa, across Nigeria, and into the global discourse that health equity is not optional, it is essential. If we dare to commit, then indeed change is not only possible, it is inevitable. I want to thank all participants for listening. I want to thank the organizers, and I want to thank the authority of our unique Uniport for giving us this platform to contribute to the development of healthcare, not only in Bayelsa River State, Nigeria, but also across Africa and the world indeed. Thank you, and God bless all of us. Thank you so very much.
Thank you, Chairman. What a wonderful speech with so many quotable quotes. I'm sure that these quotes will appear in the next examinations of our students, and they have been told. So they have to take note of what our chairman has said. Thank you very much, Chairman. The next Goodwill messages. I don't know. Can I call on Professor Gaji? Professor Gaji is actually wearing triple hats because he's also the chairman of the Health System Caucus of the Association of Public Health Physicians of Nigeria. Professor Gaji, sir. Hello?
Okay, he has unmuted me.
Yeah.
To be unmuted. Thanks so much. And yes, like you rightly said, I'm going to be speaking now on this Goodwill message as the chairman of the Health Management Caucus of the Association of Public Health Physicians of Nigeria. And may I recognize and stand on the already established or well-established protocol, by the director of the School of Public Health. It gives me great pleasure to convey the goodwill of the Health Management Caucus of the Association of Public Health Physicians to the management, faculty, students, and even alumni of our distinguished School of Public Health on the maiden annual scientific conference and alumni meeting of the School of Public Health holding in this last 2 weeks of September. The choice of the conference theme, which is Translational Research for Improved Service Delivery and National Development, and a sub-theme specifically for the Health System Management Day, which is Equity in Healthcare Delivery in a Changing Disease Landscapes, are both timely and visionary. It speaks to the urgent need for bridging research evidence with practice, while ensuring that no population group is left behind in accessing quality health services, especially in the face of evolving epidemiological and socioeconomic realities. We've heard a lot from the chairman, who is an active leader in the sector in a difficult terrain. But as a caucus of the Association of Public Health Physicians of Nigeria, we are very proud of the Health System Management Division of the School of Public Health and all the programs that have emanated from this division since inception. These have contributed immensely to the development of critical human resource for health, not just in Nigeria, but in Africa. We firmly believe that strengthening health system management is central to achieving equity, resilience, and efficiency in healthcare delivery. Today's gathering provides us invaluable platform for cross-pollination of ideas, partnership, and innovative solutions that can transform Nigeria's health system and contribute to sustainable national development. We've seen that we are fielding an array of frontline professionals, both as keynote and address, and in the discussion section during the panel section. And we believe that all the objective of today's section will be achieved. Now, on behalf of APHPN Health Management Caucus, I commend the University of Port Harcourt School of Public Health ably led by the director, Professor Best Odinoha, for this bold initiative. And I urge all participants globally and virtually to engage meaningfully, translate knowledge into action, and uphold the noble mission of advancing health equity within the health system in Nigeria and in Africa. I encourage every participant here today to be part of the final and second scientific section that will take place after this opening ceremony, where research of students in the health system management division, will be showcased. There's a lot to learn and to share. We wish the organizer and participants a successful conference, fruitful deliberation, and enduring impact on the future of healthcare delivery in our nation. Thank you very much, and enjoy the rest of the section.
Thank you very much, Professor DSC Ogaji, as the chairman of the Health System Caucus of the Association of Public Health Physicians of Nigeria. Thank you very much, sir. I don't know if Professor Usochukwu is here, or any representative of the health system global. I don't know. If you are here, you can raise your hand. That will be delivered by Dr. Obinna Oleribe. Even with the time difference, is online with us, so we'll hand over to him. Okay, thank you very much. So we can move on to we'll take of the keynote, and then followed by the keynote lecture itself that will be delivered by Dr. Obinna Oleribe. Dr. Oleribe, I'm sure you can, if you indicate, probably.
I'm here.
Raise your hands. But, okay, thank you very much. Please, can you just make him a co-host so that.
I'm already a co-host, Best. Thank you. Hello, Best. Can I take over?
Dr. Obinna Osita-Dimma Oleribe won a unanimous vote to deliver. Dr. Obinna Osita-Dimma Oleribe won a unanimous vote to deliver the keynote address at the first annual scientific conference of the University of Port Harcourt School of Public Health. He received this recognition for his academic and professional qualifications, his wide-ranging experiences, and for being an award-winning student, engaging lecturer, life coach, mentor, and most especially an influential practitioner of public health in Nigeria, across Africa, in Europe, and now in the United States of America. A 1995 graduate of the University of Port Harcourt Medical School, Dr. Oleribe finished with multiple subject prizes and emerged as the best graduating student. Though he was expected to immediately pursue a career in academics, he chose instead to concentrate on running the Anti-Child Abuse Society of Africa, the NGO he founded as a medical student, and later its spin-off, Excellence and Friends Management Care Center, Public Health Solutions. To strengthen his service delivery, Dr. Oleribe sought knowledge at leading institutions worldwide. He obtained a Master of Public Health from the University of Benin, Nigeria, a Doctor of Public Health from Walden University, USA, Fellowship of both the Royal College of Physicians, London, and the West African College of Physicians, 2 Masters of Business Administration degrees from the University of Nicosia and Imo State University, and certificates in Project Management Professional and Managing Healthcare Delivery from Harvard Business School. His deep understanding of global health systems made him a highly sought-after consultant. He has collaborated with and consulted for several national and international organizations, including the World Health Organization, the Centers for Disease Control and Prevention, Broadreach Consulting Group, the Nigeria Institute for Medical Research, the National Agency for the Control of AIDS, the Royal College of Obstetricians and Gynecologists, Family Health International, IntraHealth International, the Health Systems Development Foundation, and the UN Foundation and eHealth Africa, among others. Dr. Oleribe is currently a faculty member of California State University, Dominguez Hills, where he teaches public health and management concepts, conducts research, and provides services aimed at improving community and institutional health. He is also an active member of professional organizations in the United States, including the American Public Health Association, the American College of Academic International Medicine, the Project Management Institute, and the Society of Public Health Educators. Ladies and gentlemen, behold Dr. Obinna Ositadinma Oleribe, medical doctor and celebrated public health physician, Fellow of the Royal College of Physicians, London, Fellow of the West African College of Physicians, Secretary, American College of Academic International Medicine, Governing Counselor, American Public Health Association, and keynote speaker, Day 5 of the first annual scientific conference of the University of Port Harcourt School of Public Health.
Bess, you're muted.
I want to believe he wants you to start.
Okay, so great. Thank you. Good morning, Professor Best. Good morning, Ogaji. Good morning, everybody here in Port Harcourt today and around the world. That citation nearly got me crying and shedding tears. I remember the very beginning when we were all there in Port Harcourt trying to get our bearings on medical sciences and what God has done over the past several years. It's an honor and a privilege to be here this morning. It's just about 3 a.m. here in California, where I live, but I've stayed awake tonight because I believe that this is very critical and important day in the annals of our great institution. And I'm glad and privileged to be part of this first inaugural scientific conference of our college. I recorded a message for today, but I was not sure if I would be awake or not. So allow me to just play the recorded video, and thereafter I'll take your comments and your questions. And thank you, Sefa, for that amazing presentation. That was awesome, awesomely delivered. Let me see if I can find my presentation, and then. Why can't I find you?
And
Are you seeing my screen?
Not yet. We're seeing just your video.
Oh, sorry. I need to.
You need to share your screen.
Okay, I think I'm sure you're seeing my screen now.
It's coming. Yes, we're seeing it now.
All right. Thank you. Morning and welcome. Today, I believe, is the 5th day of this amazing convention put together by innovative, creative, and pace-setting faculty of the University of Port Harcourt Teaching Hospital, School of Public Health. My name is Obinna Oleribe, and I'll be addressing this September audience on this topic today: what is your why? I schooled here several years ago, the 1987 sets, finished 1995, and I'm a proud alumnus of the school. And over the years, one of my greatest right decisions was coming to this school to be a student, and today to talk to you on this amazing conference. I'm glad you're here this morning. I'm glad you made the choice to come, and I'm glad you're learning, because I strongly believe that this conference will leave a mark in your personal life and also in your career endeavors. Sorry. The theme of the conference is Translational Research for Improved Service Delivery and National Development. And I have been given the honor task of looking at a sub-theme, Equity in Healthcare Delivery in Changing Disease Landscape. I believe that it's not only the disease landscape that is changing, the entire world of public health is changing, particularly with the evolution and revolution being caused by AI globally. But tonight, I will not focus on AI, even though that is my current area of interest, and we can talk about that maybe some other time. But today, this morning, I want to focus on what is your why. This simple question defines my full presentation today. Why did you choose this program? Why did you decide to attend this particular conference? Why are you here today on this 5th day in a program created by the faculty and students to showcase research achievements of the students and faculty of a very pioneer school of public health in Nigeria? Over the past 4 days, I believe you have heard from distinguished faculty, respected professionals, and thought leaders who have illuminated crucial topics across public health and epidemiology. Today will not be different. Following my session, you will engage with experts in environmental health, population, and reproductive health. You will also look at community health, public health nutrition, health promotions, communication, and occupational health. The conference is really, really rich. Throughout this conference, friends, you have learned and will continue to learn from individuals who have made enduring and lasting impact on public health space. From those striving to make that difference, and from those who have sacrificed greatly to move public health from where it used to be to where it is today. I truly count myself to be among the last group. Those who have paid personal price to follow a calling. After graduating from this medical school in 1995, my mentors envisaged me as a surgeon or obstetrician, or at least an internist, fields they believed held the highest respect and financial reward. But I chose a different path. I chose public health. And I chose it with intention. So I ask you this morning, what is your why? I became a doctor because my father wanted me to be. I suspect some of you have similar stories. My own dream was to be an aeronautical engineer, to build my own plane and to fly it. I actually got admission to study aeronautical engineering at about 29,000 pounds at that time. But since my parents couldn't afford that amount of money, my father encouraged me to do something different. I decided to go for electrical electronics engineering, which I thought was close to aeronautic engineering. But then a single letter from my father changed my trajectory. So I set aside my personal dreams to fulfill my father's deep wish for me to study medicine. Even after his passing during my first semester here at University of Port Harcourt, I carried on with that promise, studying relentlessly, investing my energy and striving to be the very best in my class and my profession. When it came for me to decide where to spend the rest of my life, a specialty, I told my devoted teacher something that at that time felt bold and maybe arrogant. I said, one day, public health will be the field every doctor and healthcare professional will want to be in. Today, we are living in that very reality because surgeons, gynecologists, everybody is running to do public health, MPH, DRPH, PhD, because they understand that without public health concepts, you are myopic, you will not go too far in the current space. But why did I choose public health? One day, while undertaking my clinical postings in town as a medical student, a child was brought in for routine circumcision. What struck me was not the procedure, but his journey to the hospital. He had come from a prison here in Port Harcourt. He was born there to an incarcerated mother, and after the circumcision was to be taken back to prison. I found this unconscionable. I was angry, very angry enough to write my first article, Prisoner from Paris, in the Daily Sun newspaper. That article surprisingly earned me an invitation to the government house for questioning, but it also became my aha moment when I realized that we can and we must do something to end all forms of child abuse and child neglect. So while in medical school, I began to take steps. That moment gave birth to several nonprofits, beginning with the Anti-Child Abuse Society of Africa, ACASA, which many people know me by. From ACASA came books such as The Concept of Child Abuse and The Fundamentals of Child Rights. ACASA also gave birth to other nonprofits since then, when a woman accused me of not caring for the family because a child cannot have a healthy life outside the family. So I formed the Center for Family Health, initially as a hospital, and then the initiative as a nonprofit. And also when I began to run HIV program and grants, I founded the Excellence and Frame My Main Care Center in Abuja and several other initiatives. Through trainings, meetings, and conferences like this, I discovered the immense power of policy, the impact of empowering individuals, that's the people, and the transformative role of government politics in addressing people's problems and needs. At that point, friends, choosing public health, which is a process, was no longer a question. It was the only logical option. So let's get to today's topic, equity. Equity in healthcare delivery in a changing disease landscape. Understand this, friends. We are gathered here today under this theme. There can be no true equity in healthcare until we first understand what equity truly means. Long before equity became the new flag to wave, I had already been on the front line. driving equity here in Nigeria. I founded ACASA with one driving mission: to ensure that every child received equitable services, no matter their background or circumstances. And I started EFMC in Abuja to ensure that everyone diagnosed with HIV received equitable care and treatment. When children with anemia were denied life-saving blood transfusion here in Port Harcourt by their parents' beliefs, I stood up and fought for them. When young girls were subjected to cruelty of female gender mutilation and child marriage, I raised my voice and fought against it. When the US government HIV program offered care to only a select few of Nigerians in a handful of states, I refused to accept such limitations as the norm. Instead, I championed decentralization and commonization of HIV services, such that everybody, no matter where you lived, where you worked, where you played, could have access to HIV services. And this brought HIV testing and care to where people lived, worked, and even along travel corridors in southwestern Nigeria. With HIV drugs restricted only to people that had CD4 count of less than 200, while unused medications were allowed to expire and be incinerated, I broke the convention. I broke the rules. I ensured that every person diagnosed with HIV across my service sites could access treatment, regardless of their CD4 count. People fought against it. People said all manner of things against it. And today, I'm glad to announce that it's a national program. To make a change, somebody must get out of the box. And I did that in HIV world. These are some of my publications on what we did. You can just scan the QR code or go to Google Scholar or PubMed and type my name and the topic, and the articles are all free access. You don't need to pay to read my work. What did I do? During my time at CDC Nigeria, I worked with the government and I worked with CDC and US government to push service delivery sites from just 180 centers to over 1,000 centers in Nigeria. We also moved program from 12 states to all the 36 states and FCT in just 3 years. As the CEO of Excellence and Fair Management Care Center, I refused to close my doors to fresh graduates in Nigeria, while other organizations were employing those who they believe had experience in programming, in public health services. I and my team took it upon ourselves to employ just fresh graduates who just finished an NYSC and train them, mentor them, and build them and equip them to become experts in public health. Today, many of those same individuals that people rejected are leading public health services across Nigeria and beyond. I have a number of them here in US right now, working for CDC and other organizations. We did not just think outside the box. We destroyed the box. So equity is not a buzzword. For me, it's not a buzzword. It's not a policy slogan or the latest flag to wave. It is a way of life. In Nigeria and around the world, I have worked to embed equity into child health programs. In OVC, for instance, in community participation and involvement, in several health programs, social services, and community systems. Today, therefore, as we focus on equity in healthcare delivery in a changing disease landscape, we must first understand what we really mean by the term equity. healthcare delivery, and changing disease landscape. The pictures you're seeing right now are what we see regularly on Google search on what equity stands for. That equity does not mean equality. Equity is unique. Equity does not equate to having the same services for everybody. But equity gives people the same thing. Sorry, why equality gives people the same thing? Equity ensures that each person gets what they need, when they need it, where they need it, and the way they need it. True equity therefore recognizes individuality because everyone have a different need, different expectation, and different challenge. Equity recognizes educational levels of people, their income and cultural beliefs. Equity is so important because it does not mean giving everyone the same level of attention, paying everyone the same rates, or making everyone work the same number of hours. Those may be examples of equality, but friends, they are not equity. So what is health? I know that over the years you have been trained with the WHO Division of Health, which came up in 1948, as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. But to me, although this was visionary, it is neither specific nor operational. That's why in 2018, my team and I developed a new practical and operational definition of health, one designed to guide action, not just aspirational. We defined health as a satisfactory and acceptable state of physical, mental, emotional, economic, and social well-being. We added economic because money is critical to your health. This state should result in maximum productivity, positive contributions, and relevant existence in a degenerating and decaying world, in a changing landscape. It is a state of having the overall physical, mental, emotional, and social ability to add value, not just to oneself, but to the society, resulting in the development of a better and a sustainable world where things work. Where things work. Where people live in harmony and community existence is enhanced. What do we mean by care delivery? Care delivery can be formal or informal. In Nigeria, we have both. And both are vital. Formal care delivery in hospitals, clinics, and even in pharmacies cost money. You have to pay to register for consultations, for drugs, for lab tests, for admissions, for surgeries, for deliveries, and much more. Even sometimes you have to pay to fast track your therapy and services. And in this country where insurance is so far and in between, people have to pay from their pockets. So why a doctor here in Nigeria, I saw people who should not die because they couldn't afford care. Informal, however, care, which is very important in Nigeria, happens through families, friends, and communities, often on a pro bono basis, and remains one of the strongest pillars of care in our society. Finally, what do we mean by changing landscape? When we speak of a changing disease landscape, we are referring to the reality that despite the great victories of the 20th century in controlling infectious diseases, new and re-emerging infections continue to challenge us. Alongside these are what we call the triple burden of diseases. First, communicable diseases. The infections that still persist and resurface despite all the drugs that we have because of drug resistance, pathogens like TB, strep, E. coli, 017, and reimagined infections or new emerging diseases like HIV, Ebola, Lassa fever, etc. Then number two, we have the non-communicable diseases like hypertension, diabetes, obesity, cancer, mental health disorders, including stress, anxiety, and depression, which right now is at an epidemic level. And number three, traumas and injuries, from road traffic accidents to conflicts across Nigeria right now, to individuals poisoning themselves with drugs and herbs, to self-harms, to suicide, to intimate partner violence, and for me, including child abuse and female sexual mutilation. We also live in a world today of zero international funding. I'm sure you heard what happened a few months ago when Trump destroyed USAID, stopped most grants, tried to change what happens here at the US with the National Health Institute for Health. And so grants, research grants are all going away. There's a change in landscape. Then national leadership. We have had change of government here in Nigeria at the state level, at Minister of Health level. Leadership matters. But to be able to effectively talk about equity in a changing disease landscape, we must talk about cultural humility. We must understand the culture of the people we tend to serve. Because cultural humility is a lifelong process of self-reflection and self-critique that emphasizes a commitment to learning about other cultures from the perspective of those within them, rather than viewing cultural knowledge as a fixed endpoint. I'm sure my dressing this morning speaks to that directly, actually. In case you don't know where I came from, my dressing will tell you. This is so critical for us to achieve equity in health care system, because different cultures have different problems, different health belief models. There are different levels and different stages of change. And if we do not put this into perspective, we may end up thinking that we are serving them when we are actually hurting them. The triple burden of disease demands everyone plays a significant role, not only in improving the health outcomes, but in protecting populations and ensuring the timely delivery of essential health products and services. To meet this challenge, therefore, friends, we must understand the diverse needs of our diverse population. Over 350 languages, I'm told, over 250 different ethnic nationalities in Nigeria. We must train professionals who respect and understand the cultural expectations of the people they serve. We must practice cultural humility when engaging with individuals from different backgrounds, understanding that they have some cultural assets that we can tap into to provide quality care to them. We must acknowledge historical traumas and lived experiences from Nigerians like the Igbos that shaped people's trust or mistrust or distrust of the Nigerian health system and in Nigeria as a whole. We cannot pretend, friends, that Biafra never happened. Even if we remove history classes from our schools. We must tell our children the truth, that people were killed, massacred, because they believed in themselves. We must tell people the truth, that hunger was used as a weapon of warfare, and 3 million people died because of it. We must tell people the truth, that people's income was declared useless and their houses taken over by others, and they were given 1 or 2 pence or whatever it was to start life all over again. Cultural humility will help us understand that, respect that, and give everyone their due if we want to achieve equitable system for all. That's why I want to talk to you today as I begin to round up this presentation on the 5 P's of public health. Equity in this new era demands that we understand these 5 P's: the people, the problems, the policies, the processes, and the politics. They are the 5 guiding pillars that will shape effective equity action movements. First, people. The heart of public health, friends, is people. Every strategy begins and ends with the community that we serve. Without understanding the people that we serve, their needs and their context, interventions will always fail. 2 problems. The issue we must address, from emerging diseases to systematic barriers or systemic barriers, we must define the problem clearly in the very first step before we can actually attempt to solve them. Policies talk about the rules, laws, and guidelines that govern action. Effective policies can transform health systems. Poor ones, friends, can undermine them. Processes. The systems and methods that turn plans into results. Strong processes ensure that good ideas are implemented efficiently, effectively, sustainably, and with accountability. And finally, politics. This is the power dynamics that shape decision-making. These policies can either accelerate public health progress or restall it. Understanding and navigating political realities of our days and times is essential for real global impacts. So, these again are not just words. They are vital in the changing disease landscape, actually in the changing public health landscape. I'm working on a manuscript right now on public health 4.0, asking us to run with the new changes that the world is pushing on us. In a changing disease landscape, therefore, the 5 P's are not just concepts. They constitute a roadmap for action, ensuring that our work is people-centered in the middle, problem-driven, policy-informed, politically astute, and more importantly, process-oriented. This is critical to succeed in public health space in a changing disease landscape. In the end, therefore, equity is and will always be about the people. Every action, every activity, every project undertaken in public health must be people-centered, designed to address real problems through processes that are both effective and efficient. We must never, ever forget that public health is inherently political, and it moves forward or stalls through policies. That means, therefore, that our work cannot be done in isolation. It must be informed by the communities that we serve, strengthened by sound governance, and sustained by our will and the will of the people to act. Let me ask you again this morning. Why the war? I told you earlier today that we had to not just only think outside the box in public health services in Nigeria and across the world, we had to destroy the box. Why do we need the war in the first place? As I end this presentation, we must begin to think of how to eliminate, eradicate, and forever destroy every wall hindering people from seeing, from assessing, and from becoming who they want to be. I challenge you, therefore, this morning to find your why and hold onto it. Let your why guide who you desire to become, how you treat the people that you serve, the problems you choose to solve, the policies you help to shape, the processes you improve and run with, and the political space that you want to navigate. Friends, because in public health, equity is not just a goal, it is a commitment. Remember that these commitments starts with you. So what have been my journey? I schooled here at University of Port Harcourt, did my residency here so many years ago, maybe before some of you were even born. Served in Naval Dockyard in Lagos. Had private practice in Bethesda Hospital in Abuja, and then opened my own clinic in Goodwill to serve the community because I believe in equity. Then got a job with the Federal Minister of Defense to work at National War College, which is now National Defense College, Abuja. Then came to UNT Enugu to do my residency and in Benin for my MPH in public health. And then went back and worked with CDC Nigeria, where I expanded the HIV program from 12 states to across the country. I had to enter that box to go through my degree everywhere in this country. Then I went to Tanzania as an expatriate and helped them to build their Tanzania Field Aid Training Program. I came back on an invitation from a friend and founded this EFMC, SPH-UNIPORT, and Modern Health Hospital, and several other initiatives. In 2020, I left Nigeria in the midst of COVID to go to US and became the general health manager of the Climate Force Tribal Systems in Oregon. Then thereafter, I left and came to California, where I served first as a deputy chief of public health in Orange County, a county of about 3.2 million people, controlling COVID and transitioning the system back to business as normal. But because I have always desired to teach, which in my personal program, my personal why, I didn't want to teach for money. I wanted to teach because I love teaching. I wanted to first make money, see the world, and then teach. I joined full-time faculty position at California State University, Domingo Hills. But before then, I've been teaching here as a visiting professor and also in University of South Wales as a part-time faculty. This has been my journey. The QR code takes you to my LinkedIn page where you see a little bit about me as well. What, friends, is your why? Do you know your why? Have you found your why? Are you running with your why? If you are not, let this speech, let this presentation jumpstart that process, because you cannot be part of the equity movement if you don't know what your own why is. If you don't understand the 5 P's I've mentioned, that P of people, that P of problems, that P of policies, that P of processes, and that P of politics. Once more, thank you for listening, and have a blessed, enriching, informative, and very empowering conference. God bless you.
Thank you very much. Wow, what a speech. Please, let's give him a standing ovation. What a speech. Think, permit me to say, is the Oleri-based definition of health. And I so much like it because over the years, I've told students that poverty is even included in the WHO International Classification of Diseases and Infirmity, and I brought that out. The economic well-being. I like that. I've learned so much. I've taken a lot of notes. In fact, triple burden of diseases in which you highlighted these trauma and injuries, which we really need to highlight in Nigeria, where in the communal crisis, herders farmers crisis, causing us several problems. And of course, the 5 Ps of public health: people, problems, policies, processes, and politics. Thank you very much. I'm sure that we have already told our students that that what we do in this conference will form a part of their examination. And I know I have, in fact, in my head, we can tease out at least 15 MCQ questions from this lecture alone. Thank you very much, Dr. Leribe. I'm sure that the questions will come. I know you are ready. You are ready for the questions, but want to have want to close this section within the next hour or so. Thank you very much. Yes, I think I should. You are already a visiting professor with the School of Public Health. Thank you very much, Dr. Leribe. So now we'll just have a brief interlude where we'll take a cultural display and then a short clip on healthcare delivery in the Niger Delta. Please, let's have that. And after, when we come back, we'll go to the next section of the conference, the panel discussion. And hopefully, if Professor Kaji will be, if he will be around, he will be the one to anchor it. Let's take the cultural display first before this. Professor Gaji, I hope, have you gone for the condolence?
No, I'm about moving now. Condolence visit.
How do we do it now? Okay, please, let's.
How are you? Bye-bye. Oh. Immediately.
Thank you very much. We'll take a short clip on healthcare delivery in the Niger Delta. As before we take the plenary section, please. Sorry, before we take the panel discussion.
Can be found in various parts of Nigeria: Ondo, Edo, Delta, Akwa Ibom, Cross River, Rivers, and even Bakassi in Cameroon. However, there's a coastal state in the Niger Delta region of Nigeria, Bayelsa State, the glory of all lands. It consists of 8 local government areas with its capital in Yenagoa. Due to its geographical location, the natives are predominantly riverine settlers in mangroves several kilometers away from the city. Naturally, the major occupation of these people are canoe carving, fishing, farming, and trading. The Izors are very strong and hospitable people, very adept in swimming and wrestling matches. For ages, the Izors have been identified with the traditional art of body massaging, physiotherapy, and human kinetics for healing purposes. This was before the Australian bush country nurse Elizabeth Kenny in the 1940s established a training institute for the training of physiotherapists in the United States. Oral history has it that the art of massaging is a heritage bequeathed by Providence to Izzo ancestors, given their peculiar habitation and way of life, which presented with various health challenges. For instance, what could be the fate of a young wrestler who sustained injury during a local wrestling match, or a pregnant Izzo woman faced with pre- and postnatal complications? The Izzo physiotherapists, bone setters, and traditional birth attendants, who are highly revered, have been known to solve such health challenges through massaging. Massagers, irrespective of age, are always referred to as Papa or Mama by their patients. The first type of massaging focuses on bone fracture. They also take care of other ailments such as headache, general body pains, and dislocations.
Captain Gary Solomon Bame, if I could put him in a blamia, you must not go from one.
Thank you very much. I think we can now go to the panel discussion. Professor Gaji, I don't know. Hello, Professor Gaji. Has he gone for the... Hello, Professor Gaji? Okay. So let's start the panel discussion, and we have Dr. Claribel Abam, the former Executive Secretary of the River State Primary Healthcare Board, and then we also have Dr. Veti Agala, the executive, sorry, let me just get what's happened now, of the River State Contributory Executive Secretary of the River State Contributory Pension Fund. Hello, ma. Dr. Agala, Dr. Abam, and I'm sure that...
yes, sir. Good day.
Yes.
Very much here. I'm here.
We're here.
Thank you very much. So let's start with Dr. Abam. Dr. Abam, you have a rich experience in all parts of all aspects of public health. Can you just can we just have your opening remark? If you can make an opening statement before we go to the questions that we have listed.
Thank you very much, Professor Bess, for this privilege. Let me start by, I hope you can see my video.
Yes. Yeah.
Okay.
Yeah. Can you highlight, Professor? Hello, ma. Go on.
Yes. Okay. Let me start by congratulating you on this conference, the first of its kind, and coming from an institution that is training health practitioners at the public health level. I congratulate you. And the topics you have chosen to discuss are very germane, and they are very important for our healthcare system at this time. It's very crucial for us to talk about equity and to talk about how everyone can be reached and everyone can share in what is available in the country, in the health system. So it's a good thing that you're doing, and we are appreciative of it. For me, I will say that public health is the life wire of any healthcare system. And I will also want to emphasize that once primary healthcare is properly and effectively practiced, we will find that we would have solved the health problem of the country to a reasonable extent, especially when that practice is equitable. That will be my opening statement. Thank you.
Thank you very much, Ma. I forgot to also even tell them of the fact that you are probably one of the, I don't know if you are even the first chairman of the Nigerian Medical Association Rivers State branch. And of course, you are an executive of N1, the most powerful medical association in the country. Thank you, Ma. So we can go to Dr. Agala. Hello, Ma. Can we have your opening remarks?
Thank you so much. Thank you very much. And a very good afternoon or good day to all of us on the call. Let me join my voice to Dr. Abam's voice to say congratulations to the School of Public Health on this maiden, or will I say first, conference that has been successful so far. I think this is the 5th day and it's been amazing. Today has been a life-changing session for me already, listening to the keynotes and I asking myself the why along the way as we kept going on in that presentation. Dr. Abam has said something about primary healthcare being so important. But when we look at equity as the central theme, I got thinking about what Dr. Obina said this morning. And just as we were on the break, a staff came in and we were talking about a particular client. You find that when we talk about equity, is about what someone needs. So we, of course, I'm privileged to be the executive secretary of the Rivers State Contributory Health Protection Program, which is the state health insurance agency, and we have a benefit package. Just to share an experience that happened last week and then today, that we have someone who her problem is eye care. She doesn't have any other problem. What she needs is a particular eye drop. That is her need. And then we say she cannot get that. And I told my staff, no, this is her need. Her need is not even as costly as a cesarean section. But we say we can't cover that. Please cover that care. We're going to do things differently. And so Dr. Bina's presentation this morning, and of course also our chairman, gave me a perspective on how to go on with this work, how to truly take action, because equity is not just, how did the prof put it now? It's not just a goal, but it's a commitment that starts with each and every one of us. And so I'm really excited to be on the panel this morning, and I'm hoping that I can lend my voice to the conversation and actually bring out practical steps on what we can do as individuals and as communities to ensure that everyone that lives and works in Nigeria can access healthcare when they need it without going through further hardship. And of course, break the wall, whatever is bringing the walls, we want to pull them down. Thank you so much, sir. That will be my opening remarks, sir. Thank you.
Thank you very much. Thank you very much. Dr. Abam was the pioneer executive secretary of the Rivers State Health Management Board. Perhaps we should, can you just let us know of the dynamics involved in the establishment of the Primary Healthcare Board, and of course the relationship with the ministry? Those of us that we are watching or listening from outside, we had one or two disagreements over responsibilities. Can you tell us one or two things about that, the establishment of the board?
Okay, the point is that for every pioneering work, when you are starting something that is new, there are challenges that always come up because change is not readily acceptable by everyone, but change is something that is inevitable. And so when the country adopted the primary healthcare system and now decided to have primary healthcare boards across every state, and to put primary healthcare under one roof, it became imperative to move all the activities that have to do with primary healthcare under that board. And we know that primary healthcare activities, some of them cut across public health as a calling, and some of them are strictly based on primary healthcare services. And before this time, all of those services were under the Ministry of Health. The Ministry of Health had a primary healthcare department, which was supervising all the primary healthcare facilities across the states, and also the avenue for providing primary healthcare services, and some other services that like HIV/AIDS, immunization, and control of TB and malaria. All of those activities were happening at the primary healthcare centers. But the desk that were reporting on them were in the Ministry of Health. And whenever there is a national meeting, the desk has to necessarily report what has happened within the states on those diseases. And then there was also a disease control department in the primary healthcare board, which was now responsible for reporting on non-communicable diseases and communicable diseases on their own separately. So it became challenging for the Ministry of Health to release all of these desks to the primary healthcare board. But the vision that the country has is that the primary healthcare, since it provides for over 80% of services that health services that the citizens need, that all of those services should be under one management, and the reporting line will be easier, because if everything is happening under one roof, then it will be easy for government to also, supervise what is happening, look at globally the way to address challenges as they arise, and then do everything under one roof. And so it was suggested that all these things should move to the primary healthcare board, and they did move. But the people who were manning those desks in the ministry were not happy about those movements, and that was where the challenges were. But the truth of the matter is that if you come to the point of implementing health services at the local government level, at the primary level, and it is being supervised by an entity, it only makes sense for that entity to report on what they are supervising at whatever level of meeting that is happening nationally, regionally, or globally. And that is what happened at the beginning of the setting up of the primary healthcare board. And it's not peculiar to Rivers State. I think it's also the same thing that happened across the country, wherever primary healthcare under one roof was being practiced. Yes.
Yesterday, I asked Dr. Godwin Ohunda, who served for a long time as the Director of Public Health, if he has any staff at the local government or even at the community level reporting to him directly. And although I think he sidestepped that, he has sidestepped that question. But what is the relationship when it comes to disease control between the ministry and primary healthcare board, considering the fact that most of the staff at the local government and of course community level and local government have now moved to the primary healthcare board? Is there any relationship?
Yes, you see, the way the health system is set up by government is that the Ministry of Health is a policy arm of government. So when policies are being made, any policy on anything that has to do with health is made at the level of the Ministry of Health. And those policies are made based on research data that comes from the primary health system, from the field where the activities are taking place. So all of the data that comes from the field is used by the ministry to generate information that will lead to policies. So that's how the work is divided. And when those policies are made, the implementing arm of those policies are the field officers. So I was also Director of Public Health before I became the Executive Secretary. So it was easier for me to navigate because I knew what policy making was, distinct from policy implementation, which are being handled by two different entities. So the
Okay,
relationship really is if you recognize what the other person is doing and know that your input to the other person's work is vital and important, and you do it in such a way that it benefits the entire system, because no one benefits if information is not passed down the way it should be.
Yes, yeah. Thank you very much. I'm sure the students have heard you, because anyway, I think it's one of the objectives of this whole setup. It's better to hear from the horse's mouth. Thank you very much. The other thing I want to ask you, the relationship between the board, primary healthcare board, and the hospital management board. You know, they manage the hospitals. It's as if they are in charge of the curative aspect, and the primary healthcare board, mostly the preventive. But when you, with the kind of health centers we have in Rivers State, in fact, I think it was even an accreditation team that came to accredit, and we took them to one of those health centers. They were wondering if they were health centers or hospitals. So, is there any relationship between the hospital management board and the primary health care when it comes to service delivery?
Certainly, that is unavoidable, because you see, the primary healthcare system handles primary promotion of health and prevention of diseases, as well as treatment of basic diseases. It's not only promotional and prevention. There is also treatment that goes on in the health centers. But you know, once the treatment goes beyond a certain stage and needs to be referred, it goes to the secondary facility that is within that locality. So the primary healthcare board and the hospitals board work together, and they are all parastatals under the Ministry of Health. So that synergy is always there, because where there is no secondary health facility, the primary health centers in those areas tend to suffer, because when patients come and they're even referred, because the next facility available is not close enough, they usually don't go. And sometimes they have to end up in the teaching hospital because there isn't a secondary facility. But generally, the primary healthcare board and the hospitals management board work in synergy in the interest of the patients.
Okay, I think it's good to hear, because we teach the students that you have this pyramidal arrangement where you have a lot of primary care centers feeding the general hospitals and then the tertiary hospitals. It's good to know that there is a relationship, which means that the general hospitals in, say, local government, they have almost like a relationship, especially as we are supposed to be having this two-way referral system. Like if somebody is being referred from a primary healthcare center, is there any way of, do you think that, are they advised or encouraged to phone the general hospitals to expect such a patient or so? I know that you when you were there, anyway. I think there were, anyway. I don't know if you can answer that. If there is any arrangement to ensure this two-way referral system.
The two-way referral system exists and is practiced. In fact, it was more efficient when we had an effective ambulance service. You know, there was a time that the state had a very effective emergency medical service. And it played a lot of role in transferring patients from the primary healthcare facilities to the secondary facilities. But that two-way referral service does exist and is still in practice. To what extent it is now, I cannot say, but I do know that when I was there, it was effective, especially as it was supported by the ambulance services.
Yes. Thank you very much, ma. We may come back to you, but let's go to Dr. Agala. Hello, Betty Agala, ma.
Yes, I'm here.
Can you tell us more about this contributory health insurance? I don't know. Well, can you also highlight the social insurance aspect of it, or is it a hybrid? A hybrid of community health insurance and.
Thank you very much, sir. And yes, thank you so much. I'll start with the journey, just as Dr. Abam started with how primary healthcare came to be, the board. For us, we know in Nigeria and all over the world, government has always found a way to take care of the health of the people. And so years ago, different programs came on board, health for all, maternal health, different kinds of programs just to ensure that these barriers that we've all listed out, the inequities are kind of taken care of. And so for Rivers State, in the year 2000, a journey started. And that journey was the journey of free medical care program. Now, that program catered to vulnerable populations like elderly people, children under 5, pregnant women. Also, they could access CS, and people in custody, so to speak, then the legionnaires and all of that. Now, that program ran up until 2014, when it became obvious that government alone could not fund healthcare. Sometime in 2011, the government of that day expanded healthcare to everyone that lived and worked in Rivers State. At the time, the government felt that the funds that were coming to the state could cater to everybody. And so universal health coverage started for us in Rivers State at that time. But sustainability became an issue because only government was funding. And so when government had other priorities, so to speak, the health of the people was no longer primary, so to speak. I'm trying to use the right words. And so at the time, I was working in the free medical care program. And in 2014, 2015, it became obvious that we had to look into the health insurance option. And so we did that proposal and went through the motions of having a technical committee where I was serving as secretary. We came up with the law. At the time, I think it was just Delta State and Lagos State that had something that we could look at. But we did have a draft law sent to the assembly, had a public hearing in 2019, and that law was passed in the assembly in 2020 and signed, gazetted in 2021. So the Rivers State Contributory Health Protection Program, as the state insurance agency is nicknamed, came into being last year, 2024. So there was a law signed in 2021, but was not, it's like we talk about policies, it was in the shelf, on the shelf. But in 2024, our governor, Sir Siminalayi Fubara, through giving us an office, appointing myself, and then, of course, with a team of people from Ministry of Health and other ministries, we started the implementation or operationalization of the Rivers State Social Health Insurance Scheme. Now, our mandate is to provide financial risk protection to everyone that lives and works in Rivers State. So the idea is that whether you are a government worker, whether you are in the informal sector, whether you are a child, everyone in Rivers State, not just indigents, if you live and worked in Rivers State, you should be able to access healthcare when you need it without having to pay out of pocket at the point of service or further go through financial hardship. So the agency has been implementing the social health insurance model. Of course, most of what we do is in collaboration with the National Health Insurance Authority. Our law signed in 2021 was a voluntary law, the same as the National Health Insurance Scheme law, which, of course, we knew all the challenges. But in 2022, we know that the National Health Insurance Authority Act made health insurance mandatory. But by the time we were implementing, we had a voluntary law. So we started out with the informal sector, vulnerable population, funded by the states and the federal through the National Health Act. As we know, the National Health Act 2014 provided for 1% of the consolidated revenue fund of the country to be put into a basket. And that fund is to provide a basic minimum package of health services for Nigerians. Yes, we have chosen vulnerable populations, but it's actually for Nigerians. So that money is split into 4 gateways currently. And the health insurance gateway is one of the gateways. The primary healthcare gateway is another one, because we felt, and just as Dr. Abam said, as a country, we feel that primary healthcare is closest to the people. That is where more of the people are, and they can access those preventive healthcare before referral to other levels of care. So 87.25% of that fund goes to the health insurance, 45% goes to primary healthcare, 5% goes to emergency medical services and ambulance systems, which Dr. Abam talked about, because when that system works, you find that referral is a bit easy, whether 2-way or 3-way, as the case may be. And then part of it goes to public health, the disease control, Nigeria Center for Disease Control, that's 1.25. And so we started by implementing the Basic Healthcare Provision Fund, NHIA Gateway. And of course, currently, by the mercies of God, we have over 110,000 people already accessing care across the 23 local government areas of Rivers State through our primary healthcare centers and some private facilities. And then we also work on the referral system and actually do the 2-way, because you need to go for referral with a code. And of course, after that treatment, you get back to your primary provider. So that's how we've journeyed so far. And just very recently, last month, we got a board. We initially didn't have a governing board, but by leave of the administrator, we now have a board, and our structure is now fully set. Thank you, sir.
Thank you very much. Thank you very much. I was made the chairman of my community's health committee, and we have this PIA fund. And I was wondering, we are wondering how to, because we are charged with responsibility. We are charged with the responsibility of providing health services to members of my community. And I was wondering, what is the best to do? What is the best thing to do? Do we use it to pay, to register members of the community in the scheme? Or do we use it to rehabilitate our health facility, our health center, and then provide services? But what I'm interested in, you have benefit packages. How do you provide the services, especially those people in the health, in the rural areas? Like in my community, we have a health center, but they don't provide. I'm not sure that they are capable of providing those services. So how are you able to meet the requirements of your benefit package?
Thank you very much, sir. Before we started implementation, we had accreditation visits. And so we did an assessment first of our primary healthcare facilities, a second line accreditation, if you ask me, because at that time, the primary healthcare system had already done a level of accreditation to say these facilities fit the Basic Healthcare Provision Fund. They have the right infrastructure, they have the right human resources, they have basic equipment and the skill to provide the services that are primary services in our benefit package. And so we did that step 2 to go around currently 205 primary healthcare centers across the 23 local government areas of the state. Of course, you recall that we have 319 wards in Rivers State. Yeah. That tells us that a number of wards and a number of communities are not covered to access that care. And that's one of the barriers, the geographical barriers and other kinds of barriers that our community are facing. But these facilities are managed by the primary healthcare management board. Now, their role is to provide infrastructure. Of course, government provides infrastructure through them, but the Basic Healthcare Provision Fund also gives them some fund to ensure that these infrastructure are maintained, that basic equipments are available, that the right human resource at the level of the community are available. And so when we did this assessment, we were able to accredit facilities for our services. Now, as at today, we are not utilizing all of the 205 because of those facilities. I think only about 190 or thereabout were accredited. Well, in paper, they were accredited, but in implementation, we found that people could not really access care in those communities. Either they were flawed reading, or it was just something or the other, or they were in the process of renovation or something like that. So what we are doing now, in fact, my board chairman, after our inaugural meeting, made a press briefing, and we have agreed to expand because our program is beyond the Basic Healthcare Provision Fund. And so right now we are looking out for private facilities. We're looking out for even the secondary facilities to provide primary care where there are no primary health centers, and more primary healthcare facilities, even though they are within a ward. Remember that the Basic Healthcare Provision Fund model is ward-based. So we have the community participation through the ward development committees, and we work with them to ensure that they know everything happening in the facility. They know those enrolled, they know the benefit package, they know when funds are sent to the primary healthcare, and so they are able to follow up and ensure that people access care. So for your community, I think the best bet would be to sign up with RiftChip and pay per head. Currently, our informal sector plan is at 15,000 per life per annum. And based on our recent or most recent actuarial analysis, by next year, we're going to be moving up to 25,000. So this is a good time to actually key in and communities to key in to come and join us.
But the problem is, it seems one health center is choosing per ward. And unfortunately, my community is the community health center. Our community health center is not choosing because it's not, say, the world headquarters. Let me put it at that. So what do you think? What do you think? Anyway, we can talk.
Sir, I just said we are going beyond one per ward. In fact, with the Basic Healthcare Provision Fund 2.0, it's going to be a minimum of 2. But with RiftChip, it's going to be every facility that is available to provide care. And that's where we are now, sir.
Okay.
Yes,
so,
sir.
The problem with although Obio Cottage, the community health insurance scheme, the Obio Cottage Hospital has done very well. But people have problems with insurance scheme because of the delivery. You get registered, you get registered, and you are promised a benefit package, and at the end, the packages are not delivered as promised. Okay, but can we move on? We have a lot of students. How can you describe the RiftChip? Is it a social health insurance, or a community health insurance, or a private health insurance, or a hybrid? So that we can, when we teach our students, we'll be able to give example, use RiftChip as an example.
RiftChip is a social health insurance agency, and that is mostly our model. Even though in practice, it's a bit of hybrid. So we have a part that you could call a private health insurance, because in our either organized private sector or even in the informal sector, there is the different, will I say, packages based on ability to pay, so to speak, and based on the coverage of the benefit package, what you want. But largely, it is a social health insurance scheme with governments largely subsidizing and providing that cross-subsidization for instance, pensioners have recently been enrolled. They are not going to be paying from their pensions, but the state is taking that. And then the state is funding the agency and our processes. So that means we are not profit driven. And that's why we are able to provide care. Now, currently, RIFCHIP runs on a fully digitized system, end to end, from enrollment to claims management. And we are not doing that through HMOs. We are not profit driven. So you find that our QA, our call center, which is 24/7, ensures that clients are getting what we promise them. We've had cases of people refunding, monies taken for a service that is covered, and a number of that. It's a work in progress, but I think we are working on the social health insurance model largely.
Okay, so let me just take it that anyway. We'll see you as the representative of the health insurance industry. I don't know. Have you looked at the equity aspect of having the different schemes in the health insurance? Different schemes. If you have, because as a federal civil servant, I am registered, but we have a scheme for what I would say civil servants, and the higher end civil servants, like those that work in NMPC and CBN, they also have their own scheme. And of course, the oil industry, they have their own scheme. So where is the equity? Where is the social solidarity? Because it is only when insurance schemes work better when the rich and the poor are in one basket, so that the rich will help subsidize the services for the poor. And that is why the co-payments is very, very high in the health insurance scheme that serve the ordinary civil servants. And of course, the benefit package is limited, and you can't compare it with probably a scheme for the CBN and the NMPC workers. I don't know, when decisions are taken, do you people consider the equity component of it?
Absolutely, sir. For us, in fact, looking at the 5 Ps that Doc talked about, and when we started this agency, and that brings us to the why, because until you understand your why, you wouldn't know how to get to where you want to get to. We have in RIFCHIP, we have our vision, mission, but our core values is an acronym we name ACQUIRE. And ACQUIRE is for accountability, client-centeredness, quality care, Q&U. And then we look at responsiveness, respectfulness. I think there are 3 things in that R. And we look at being innovative. We are very, very flexible in the scheme. And, it's almost like we are throwing the box away, like Prof said, Dr. Loribe said, because we understand that the contexts are different, and we are doing it how it suits our context. So for the formal scheme, of course, our law states that 5% from the employee and 10% basic salary from the employer. That in itself is equitable. So if you're a permanent secretary, maybe you earn 500,000, it is 5% of your basic. If you're a level 7 and maybe you earn 80,000 or whatever, it is 5% of your basic. You're not paying the same thing. And in all honesty, you are assessing almost the same care, if not the same. It's something we don't put out there, but it is one benefit package.
We know how well the civil servants are paid. So what I'm saying, what I'm driving at is probably when you bring in the rich You wonder how much money, how much tax, or how much tax Dangote will be paying. If you bring his money into the basket, he's able to, like the National Health Service of the UK, you will see that they provide a lot, even up to cutting-edge, innovative medical treatment. So it has to do, because the quality of services delivered or provided by insurance schemes is actually determined by the amount of money at their disposal. And that amount of money, if you go and gather the informal sector, those daily wage workers, how much money are you going to? It will end up providing the most basic health facilities, services, and it will not be able to provide some services. And of course, we are getting into these non-communicable diseases, diabetes and those things, where the treatments maybe are usually more expensive. Thank you, Dr. Agala. Thank you. I think I like your passion and I like your reaction time. And that is what we like, especially for public office holders, those that know what they have been appointed to do. Thank you very much. I understand Professor Ijoma Ndoka, the CMD of the Abia State Teaching Hospital, is around. Hello, ma. If you are, can you just...
I'm here, sir. I'm
okay,
here, sir.
thank you.
Thank you.
Thank you very much, ma. Thank you. This is... thank you for finding time to be with us. Thank you very much.
Thank you.
Yes, I know she's a consultant public health physician, and she has a lot of experience in managing health services at the tertiary healthcare level. Thank you, ma, and welcome. How do I begin? Can you just tell us a little about the relationship between your tertiary hospital and the other hospitals in your state? Because you are supposed to be at the APES providing specialist services. How do you relate with them?
Thank you, Prof. I, like the other panelists, started with a brief introduction and opening remarks. I also want to join them to congratulate the School of Public Health for the great strides that we see in the country. And being the first in the country, you are setting pace. Well, Prof, I don't expect anything less. Being my teacher and having passed through residency under you, I still see that drive and that passion you had 10 years ago. It's still as though you're still as young as you were then when we're doing residency. So thank you, Prof. And I wish you and your team more strides. From looking at the template, how the spread of this conference, when I saw 13 days, I said, wow, who has done a conference for 13 days? But listening to your introduction, I now have a grip of why we are running 13 days. So each day will be for each program. So I really want to thank you. And then the topic for the health systems management is apt, looking at equity in healthcare delivery. So it's something that we need to discuss every day, because health equity is what we need. And in a changing disease spread, one could have the need for malaria, another person could have the need for cancer, eye problem, like Dr. Agala said. So you would treat or handle each person based on what the person presented with. That aside, going to your question, back to Abia State healthcare sector. Abia State healthcare sector, it's one that is evolving by the day, considering where we were, where we started from. With the emergence of His Excellency, the Executive Governor of Abia State, Dr. Chioma Alex Otti, we have witnessed tremendous flight in the healthcare sector. And like the healthcare delivery in Nigeria, we have the primary, the secondary, and the tertiary. I can categorically and reliably say that His Excellency has touched every aspect of healthcare in Abia. He took up the challenge of renovating, retrofitting, and equipping 200 primary healthcare centers in the state. And in the past 1 month, we have been going to operationalize this healthcare. His Excellency did not only retrofit, he also equipped the healthcare. You can imagine a primary healthcare center that has a point of care ultrasound scan in all the primary healthcare centers. And in the same vein, we are training the health staff there to be able to operate the ultrasound scan. We have bedside monitors in each of the bedsides in the primary healthcare center. He didn't leave the primary. He is also renovating, retrofitting, equipping the secondary healthcare centers where you have the general hospitals. Each ward will have an ideal general hospital where if a case is missed in primary healthcare centers or cannot be handled there, will be moved to the secondary healthcare facility of note, not one that has been lying there fallow without anything happening. Right now in Abia, we are cutting across all our healthcare facilities such that the primary will relate to the secondary and the secondary will relate to the tertiary, where I am the chief medical director at the tertiary healthcare facility in Abia State University Teaching Hospital. So there's a synergy in the healthcare sector. We call it now the healthcare sector ecosystem, in the sense that it's more like there's no dichotomy. You are in the primary healthcare center, you face primary healthcare center. I'm in the secondary, you face secondary. Or Professor Ndoka is in charge of ABSUT, she's solely in charge of ABSUT. No. The ecosystem of healthcare in Abia is such that if a system fails, if the primary healthcare fails, every part of the healthcare system has failed. Just as last week, His Excellency called everybody in the healthcare sector to a meeting. And he further reiterated that he doesn't care dealing about ABSUT, and ABSUT is single. No, if ABSUT fails, primary has failed, secondary has failed. So in Abia right now, we work as an ecosystem. I can walk into any primary healthcare center, working with the executive secretary, and we can, on the spot, correct things that are not moving well. And they could also come to ABSUT, and we work together, bring up ideas. So the healthcare system in Abia is moving as one team. We relate so much and we interface with each other. Thank you, sir.
Thank you very much. Great things are happening in Abia State. Thank you very much. Thank you. Thank you very much. I don't know. I think I know you have a lot more to say, but I also know that you are very, very busy. Thank you very much. So we can begin to round up. Professor Obinna Oleribe, are you still there? I'm sure that he'll be very sleepy now. Would have wanted one or two remarks from him before we end this section. But I must thank the panelists, all female, all very cerebral, all high-ranking, and very experienced. So thank you very much. Starting with Dr. Claribel Abam. I'm sure we learned a lot from her. Dr. Betty Agala, thank you very much. And Professor Ijeoma Ndoka, thank you very much. Very exceptional. The husband we are classmates, and let me not go beyond that, but also a very very exceptional person. Thank you very much.
Thank you, sir.
So we can so we'll take, I don't know if we can take the closing remark from our chairman, Professor Brisbane. I hope anyway, he told me that he may step out, but okay. So thank you very much. Let me, as we wrap up, let me formally give the vote of thanks. First of all, we'll thank the VC, our Vice Chancellor, for the enablement and all the supports and encouragement, the management of the university, the Dean Graduate School, and of course, the GSO, Graduate Studies Officer, Mrs. Iyagba. Thank you very much. I have to also specially thank Professor Brisbane, a personal friend, a former classmate. Should I say benefactor? Because when he was in Abuja, he took us there. He took us there, and yes, and he played at that federal level. Well, thank you very much, Professor Brisbane. The keynote speaker, wonderful, Dr. Obinna Oleribe, very, very wonderful, very cerebral. At the peak, he won all the prizes in medical school, and he has continued to excel, formally reaching the highest, the peak of knowledge, which is the creativity, according to the revised Bloom taxonomy. When you begin to create, then you just know that you have attained the highest, the peak. So it's not regurgitating any lecture notes, but he's even creating concepts, including his own definition of health, which in fact I will formally adopt. I will abandon the WHO definition of health and take the Oleribe's definition of health, because I like that. I like the economic well-being. Like the economic well-being, which he emphasized. Thank you very much, Dr. Oleribe. And of course, the panelists, the panel discussants, very cerebral women. Dr. Claribel Abam, very celebrated. Anyway, in my own recollection, probably the first female chairman of the Rivers State branch of the Nigerian Medical Association. And of course, a very high-ranking official of N1 worldwide. Not
medical women, yes.
Yes, medical women worldwide. So she plays at the international level, and yes, international level. And of course, our own, yes, I said our own Veti Agala, wonderful lady, passionate. And it's good for someone to not only to deliver service, but also to deliver it with passion, willing to make a difference. And that is what we know. That is what we want from our public officials. We used to say, even as Christians, and we used to sing that we will only be remembered by what we do or what we have done. You can, yes, will only be remembered. But I'm sure that Veti Agala is chiseling her name on the rock of ages, not the science of time, but the rock of ages. So she'll be remembered because sand, if you put it on sand, it will it may it may be
Yeah,
it
the
may get
flood will
lost.
wash it off.
Yes, but if you chisel it there, yes. Thank you very much, Betsy Agala. I'm sure that when you finish with your richship, catastrophic health spending will be thing of the past in River State. And then Professor Nduka Ijeoma Nduka, thank you very much. You agreed to take part in spite of your other engagements. Thank you very much. You are, anyway, should I say that you are paying us back in good currency, um, for giving you the opportunity to train with us. Thank you very much, Ma. And thank you for all you have been doing or you are doing currently at Decision Hospital in your home in Abia State. And then, of course, I have to also thank the triple. Professor Gaji had a triple role as not only the head of the health system management program of our university, of our School of Public Health. He is the coordinator. He's a coordinator. In fact, he should have been the one giving the vote of thanks, but he lost somebody. They lost somebody in Esputo, so that's why he stepped out to go and condole with the family. Okay, if not, he will be the one. So, but I have to also thank him as the coordinator, thank him as the chairman of the Health System Caucus of Association of Public Health Physicians, and then, of course, our central leader of Esputo. So, thank you very much, Professor Gaji, and my other colleagues in our department, especially Professor Charles Tobin West, the deputy, for everything, his contributions, his encouragement, his mentorship in our department. Thank you very much. Our HOD, an A1 heavyweight, Professor Madoka, who AI yesterday predicted that she will be the DVC R&D of our university. But I'm sure that she will not only get to that office, but probably something higher in the general in Nigeria. And all the other ones, the staff of the School of Public Health, especially the admin secretary. I've told her that she has to drill me on how to pronounce her name. Thank you very much. And then the lecturers, supervisors, and students of the School of Public Health, thank you very much for your attendance. It has been massive. Please just continue to do that. Continue to do that. The attendance has been encouraging, not because we are considering this as part of your academic program and part of your lectures, although you have received lectures. We consider it that you have received lectures from Brisbane, from Oleribe, from the panelists. So please expect to find to find questions from all these presentations in your next exam. Thank you very much, all. We are going to end this section now and resume by 4 p.m. with the scientific presentation of abstracts. Thank you very much. So we are going to end with, I think in this one now, the university item first, then the national item. Okay, so let's rise for our university item. University item, not the national item. University item first, then national item.
On the green lowlands and swampy plains of the New Calabar River stands the University of Port Harcourt, a citadel of learning and excellent education, a home of academic enthusiasts, searching for knowledge and wisdom, enlightenment, and self-reliance on mission. Our hope in the future is rooted in God. The vision of our fathers shining in the stars, opportunities unlimited and equal. Our progeny citizens of the universe, from far and near, the pride of Uniport, because unique, Uniport, unique, Uniport, unique, Uniport, unique,
Thank you. The national item. National item.
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace or battle honored, and this we count as gain. To hang on to our children a banner without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty, Nigeria may be blessed.
Thank you very much. So, so we have come to the end of this section of day 5. We are going to resume by 4 p.m. to take the presentation of submitted abstracts. Thank you very much, and have the best of the rest of the day. Thank you. Thank you.